Welcome to our Medicine in Our Backyard series. This series is presented by the Newport Beach Public Library Foundation, and I'm Susan Grew. I'm the Programs Director for the Foundation. Libraries can be wonderful partners in a healthy community by providing its patrons with quality information that will help you all to make better health decisions. With this informative series, the Foundation is proud to help you, the members of our community, be healthier and happier individuals. Now, in turn, we are asking for your partnership in maintaining the health and happiness of the Foundation by becoming a member of our organization. The Foundation supports this library by providing quality programs such as this one, as well as by purchasing books, computers, and software to enhance this already wonderful library. We cannot do any of these things without your help, however. We are a completely membership-driven organization. We receive no outside funds. And so we ask you tonight to continue to help us continue to support this library by supporting us, the Foundation, today with your membership. And as always, I thank you all, our existing members, and I welcome you, our new members, tonight and to all of our programs. We would especially like to thank our Medicine in Our Backyard series sponsors, Dr. Ike Kempler and Ginny Kempler. We would also like to thank UC Irvine Health for bringing their extraordinary group of doctors here to the library tonight. This series continues through May, and our next month's lecture will be held on November 27th, and the topic will be colon health. But first, I am pleased to introduce Dr. Faysal Yafi. Dr. Yafi is a board-certified urologist who specializes in men's health. He has an avid interest in basic and clinical research, and he received his MD from the American University in Beirut. Dr. Yafi speaks multiple languages, including Spanish, Arabic, and French. But tonight we are hoping, Dr. Yafi, you are going to be speaking in English? Excuse me, he's got to change his slides quickly. Anyway, thank you all. Welcome, Dr. Yafi.
Thank you, Susan. Thank you, everybody, for being here. I almost missed the talk. I had a connection coming back from Lisbon. I was giving a talk at the International Society for Urology. I've had a lot of coffee, so if I'm jittery, I apologize. It's because of the coffee. So I'm from Lebanon through Canada and moved to California about a year ago, and I actually live about 3 blocks from here. So this is really fun for me to be giving a talk here today. So again, thank you very much for the invitation. And I'm going to be talking about men's health issues, which is a little bit probably more fun than next month's talk about colon issues. So, so when we talk about men's health, you'll see that it's going to be focused more towards the aging male, because most of the men's health conditions do tend to occur with more prevalence as men get older. So for the younger people in the audience, these things can occur to younger people as well, but they do tend to occur as you get older more frequently. So we can't fight aging. Aging seems to be the only available way to live a long life. So because of that, we need to find ways to make aging better and more fun. So if you look at this, it shows the percentage or the concentration of men over the age of 65 across the globe. The darker the color, the more there are. And if you look at this, this is in 2015. And then if you look at the expectations for 2050, you see that across the globe, the percentage of people over the age of 65 is going to go from 8.5% to almost 17%. So that population is getting bigger, and there are more and more people in this population, and certainly in the United States and North America. So it's important that we cater towards that population. But not only is this population getting older, if you look at the labor force participation across the industrialized or developed countries, if you look on the, let me see how this works. If you look on the left, you see this is in the 90s, and you look at the United States, it was about 15% of the labor force was over the age of 65. If you look at 2012, you'll see that the labor force is about 26 to 27%. So not only are men living longer, but they're living longer and participating in the workforce longer. So they're active participants in society, so it's very important for us to cater to these people. Aging is not lost youth, but a new stage of opportunity and strength. So because of this, it's important to understand that the same way we look at pediatric populations and their conditions as being different from adult population, it is the same thing for aging people. And if we think of it this way, we do understand the conditions that affect more prevalently people who are a little bit older, and we can address these better. So what are the urological conditions that are associated with aging? So if you look at the kidneys, you've got renal chronic kidney disease, kidney stones, kidney infections, nocturia, which is when the kidney starts producing a lot of urine at night. When we look at the bladder, it's urine infections, overactive bladder, that's when you start going to the bathroom very frequently, irrespective of having a large prostate. Incontinence, which is leakage of urine, which can be because of multiple reasons. Bladder malignancies occur more frequently as well. When we look at the prostate, it can be an enlarged prostate, which can lead to obstruction, can be prostate cancer. And finally, when we look at sexual, which is my area of expertise, you can have more erectile dysfunction, more ejaculatory dysfunction. That can be either a delayed ejaculation. Some men are unable to reach an orgasm as they get older. Some men start having ejaculations that are premature, which means they come earlier than they would like them to. And low testosterone is another one. So if you look at the ones that are highlighted in yellow, these are the ones I'm going to touch on in this talk, because obviously it would be very difficult to cover all of urology within this short period of time. So erectile dysfunction is basically when the erections don't work anymore. And it can be due to organic reasons, which is the body, relational, which is the couple, or psychological, the mind. Women tend to think that women's sexuality is a very complex concept with all these buttons that you see here at the bottom, and the men are just an on-off switch. It is true to a certain extent, but not completely true. If it were, I would not have a job. So men's erectile function is actually a pretty complex process. A man can have a poor erection because of a combination of psychological issues, but also nerve issues, such as men who have had diabetes, strokes, brain tumors, spinal injury, or even have had their prostate taken out. Or it can be because of vascular issues, which is a problem with the blood flowing to the penis, such as men who have peripheral vascular disease or heart problems, or a problem of something we call venous leakage, which means that the blood will come into the penis, but it will leak out of the penis before a man is able to get an erection. And the analogy to this is if you have a sink and you open the water into the sink, but you keep the outlet open, you can open the tap as strong as you want. It's not going to fill if it's leaking out. And finally, and it's often neglected in a lot of practices, is the relational component of an erection. So usually to have intercourse, you need two people. So if there are problems between the two people, then there will be problems. So these are all issues that we address when we see patients. So this is a very large study called the Massachusetts Male Aging Study. And what it shows is that as men get older, the frequency of problems with erections will get higher. And as you can see, the curve is going up on the right side of the screen. And if we look at numbers across the board, erectile dysfunction affects 40% of men aged 40 and up to 70% of men aged 70. Actually, 1 in 3 men will experience erectile dysfunction in their lives. And 1 in 4 men who come to the clinic with erectile dysfunction are actually under the age of 35 for multiple reasons. So it's important to recognize that this is a problem for all age groups. It is more prevalent though with age. So I'm often asked, patients come to me and they ask me, part of my questionnaire is I always ask patients, are you sexually active? Are you able to have erections? And they tell me, I can't have an erection. I talked about it to my primary care physician. He said, I'll forget about it. You're 75. Why do you care anymore? Well, is it true? Are older men sexually active or are they not? These are 2 studies. One is British and one is American. The British one shows that for men aged 70 to 80, that's the red column, 60% of men are sexually active. So that's pretty impressive. And if you look at men aged 80 to 90, about a third are still sexually active. And if you look at American population, about a half of men over the age of 70 are still sexually active. So the answer to this is age is only a number. If you still feel that you want to be sexually active, you have a partner who is sexually active as well and would like to be sexually active, there is no age cutoff. There are ways for all patients of all ages where we can address erections. So my answer to are older men sexually active is yes. So the other thing is, and this is a good argument for men who want to convince their partners to have sex, is sex keeps you young. This is a survey of 73 participants between the ages of 50 to 83, of which a third were male and 2/3 were females. And they found that greater frequency of sexual activity was associated with better overall cognitive function in terms of verbal fluency, but also in terms of visual spatial ability, in terms of being able to see and recognize things. And this is from a psychological journal, and this was just published a few months ago. So this is also very important. So what are the risk factors to having poor erections? Beyond aging, alcohol abuse, smoking, an unhealthy diet, especially having processed foods that have a lot of toxic material in them, environmental factors, pollution, obesity and the metabolic syndrome, which I don't have a slide here, but are on the rise quite exponentially, especially in North America, stress, medications, surgery such as prostate cancer. The prevalence of prostate cancer is pretty high, and a lot of patients do get prostate cancer surgery, and the rates of erectile dysfunction are higher afterwards, and low testosterone. So this is very important. Erectile dysfunction is a risk factor for coronary artery disease. Actually, we now know that the number one predictor of a man having coronary artery disease or an MI or a heart attack is worsening erectile function. And the reason is, if you think of it just by simple size, this is the size of an artery in the heart, and this is the size of an artery in the penis. So by the time this artery is clogged up in the heart, this one's clogged up much earlier. And when this one starts clogging up earlier, the manifestation is worsening erectile function. So often for these patients, I do an investigation and I find that they're a little bit younger, their erections are not great, and I will send them to the cardiologist for screening. And we often catch patients who do have heart issues, and we catch them earlier. And this is part of the preventative part of men's health. So this is how we find out if there is any vascular issues with the penis. So this is called a penile ultrasound. I do this quite frequently in the clinic. I do about 6 or 7 a week. So I think that's obvious. There's the ultrasound machine. I inject the penis with a very small needle that it is basically a very strong dilator of the veins, the arteries in the penis. The penis will get erect, and then we measure the blood in and out of the penis. And I can tell whether there's a problem with the inflow into the penis, or like we discussed earlier, that the blood doesn't stick in the penis and leaks out. And accordingly, we're able to treat. I'm not going to go over the right side. This is just to make it look like it's very impressive and I know what I'm doing. Yeah. So what are the treatment options for erectile dysfunctions? We've all heard about the pills. So we have Viagra, Cialis, Levitra, Stendra. There's a bunch of Korean different ones. And they all work more or less similarly, and I have a slide to show you about these. The other options that we have, on the top right, we have a vacuum erection device. This is a device that if any of you has ever watched Austin Powers, they call it the Swedish pump. It's basically you put it on the outside of the penis, you press a button, or there's another one that's manual, and it's basically simple suction. It sucks blood into the penis, and once the blood is sucked in the penis, you put a small band at the base of the penis, and it traps the blood in the penis. It works well in the fact that it's cheap. You buy it once, you use it for life. It doesn't feel like a normal erection. It feels like someone filled the penis with water. The glans, the tip of the penis, doesn't get erect. And usually the biggest complaints that we get is from the female partners, because they complain that the penis feels cold. And I've had patients partners tell me that it feels like they're having sex with a corpse. I'm just repeating. The bottom left one is the injection. So these are injection therapy. These are used very frequently, especially after prostate surgery. So if you look at the image here, this is a penis in cross section, means this is the length of the shaft and we cut it in cross section. There are two spaces that fill with blood. We call these the corpora. And this is the urethra through which the urine comes out. So you put the needle into either one of these spaces, they're connected to each other, and they're gonna increase the flow into the penis. The man gets a strong erection, usually for about 45 minutes, and it's a lasting erection. It works very well, but you have to adjust the dose accordingly, and you may get an erection that doesn't come down after 4 hours that you need to go to the emergency room. You probably have heard this very frequently on advertisements for Cialis, especially if you ever watch a football game. There's always at least 5 advertisements about erectile dysfunction. So they always talk about an erection that doesn't come down within 4 hours. It rarely happens with the pills, but it does happen with the injections. The bottom right one is called Muse. It's a suppository from the front, not from the back. You put it through the tip of the penis, and it's the same medication as the injections, and it's just going to bring in blood flow into the penis. It works well, but it burns after you urinate afterwards. So what do we do when all these options don't work? This is when we get, I'm just going to quickly show you a slide about the pills. So in terms of the pills, the Viagra, Levitra, Cialis, they all work more or less similarly. Each one has a little bit of an advantage over the other one. Viagra tends to be, subjectively, I find, talking to my patient, causes the most headache, and it can cause a little bit of visual discoloration. Cialis can cause a little bit of muscle ache. Viagra and Levitra, common mistakes people do to have a big meal when they take them. You have to be on an empty stomach when you take it, or at least not have something fatty, and it works best. And they all work within an hour of using them. Cialis has the added advantage that it lasts for a longer period of time. So we call it the weekend pill. It lasts for about 36 hours in your body. Viagra and Levitra usually last about 4 to 6 hours. So these are the main things. With Cialis, it doesn't matter if you eat or you don't eat. So these are commonly asked questions in the clinic, and often things that patients don't know. But the most important thing to all of these pills, and the most common mistake men do, is that all these pills require stimulation. So often patients take these pills and sit and watch football, and they're waiting for an erection. Unless you really have a thing for football players, you're not going to get an erection. That's not how this works. So what do we do when all of this doesn't work? Then we go to the penile implants. That's surgical. So there are 3 different kinds of penile implants, but I'll just show you here, and these are simplified. These are just malleable rods. These are rods that are placed in the penis. All these surgeries take about 45 minutes, and you go home in the morning. But these take about 45 minutes. You put these rods inside. They're made of silicone. And basically, they're semi-hard at all times. So they're never completely soft and incredibly concealable, and they're not incredibly hard when a man is trying to have an erection, but they work pretty well. We very rarely put them because we have a better option, which is the inflatable implant. This has a little pump, 2 cylinders made of silicone, and a reservoir that's going to go in the belly. All of that is made through a small incision that's about this big at the base of the penis, and has the added advantage that it just works by hydraulics. So you press the pump, the water will go from the reservoir to the cylinders. The man is able to keep an erection for as long as he wants. Once he's done, he presses that little deflation button, the water is going to go back in the opposite direction. I often joke with my patients that if you're having sex with your partner and you're done, you can go to sleep and just tell her to close shop when she's done. It's going to stay up until that pump is pressed. So just so you know. So I have a little video that shows how it works here, so I apologize, it's a little bit graphic, but these are the cylinders in the penis. Remember, there are 2 spaces that fill up with blood. They're going to be replaced with the cylinders. This is the little pump, and this reservoir is in the belly. You press here a couple of times, get an erection. When you're done, you're just going to press that little button, and it's going to go in the opposite direction. So this sounds crazy, but this has been around since the 70s. And we do it quite frequently. We do about 6 a month at UC Irvine. And for certain men, this is the only option they have, and it works great. So let's talk a little bit about ejaculations and orgasms. So the average time to ejaculate for a man is about 5 minutes. Premature ejaculation occurs very frequently, and it occurs very frequently in men who have bad erections. It occurs in up to 1 in 3 men, so it's very common. The definition is it means it always or nearly always occurs prior to or within 1 minute of vaginal penetration. The reason we say vaginal, not any kind of penetration, is just based on the definition that is used by the International Society. But that definition of 1 minute applies to any kind of intercourse. It is described as the inability to delay ejaculation. It often has negative personal consequences because the other partner will be left unsatisfied. And it can be lifelong, or it can be acquired with certain partners. Delayed ejaculation is a condition in which it takes an extended period of sexual stimulation for a man to reach an orgasm or climax. And this can be quite problematic to a lot of men who will just give up because the partner gets really tired and says, you know what, especially some of these patients are a little bit older, said, you know, I can't keep on going like this, so they stop, and it becomes quite problematic. And anorgasmia is the most serious of the bunch. It's the persistent inability to achieve orgasm despite responding to sexual stimulation. And this is really quite frustrating to patients, and it's sometimes a little bit difficult to treat, but we do have a lot of tools that we're able to use. So when we look at premature ejaculation, one of the first things we talk to the patient. We do some behavioral therapy. Sometimes sex therapy is needed. We have some topical anesthetics, which is this thing here on the left. I'm not advertising for this. I don't make money out of this, but this is I don't make money out of any of the products I'm showing. These are just for examples. This is a spray that just basically numbs the outside of the penis. It's available over the counter. It works pretty well, and it's usually the first line option that we use. If this doesn't work, we use antidepressants, and antidepressants actually work really well at delaying ejaculation at a low dose. We are now looking at using Botox for that purpose, but this is still quite investigational. For men who have delayed ejaculation or inability to orgasm, the first thing is always to check the testosterone, the male hormones. Sometimes when the male hormones are low, that's the reason. But if we fix those and they're still having issues, there are other hormonal therapies that are available. This is called cabergoline. The neurosurgeons use and the neurologists use it a lot. And it blocks one of the hormones that comes from the brain that inhibits sexuality. And oxytocin is basically the love hormone. You can take it about 5 minutes before intercourse. It's just a little tab you can suck on it, and it works pretty well in a lot of patients. So these are options that we have. So I'm going to talk now about testosterone and low testosterone. So low testosterone is also known as hypogonadism. And it decreases with age. Now, it decreases in all men as they get older, but once it decreases beyond a certain point, it can start causing symptoms, and that's when it becomes the condition known as hypogonadism. The obviously marketing required it to have a new name, so they started calling it andropause or menopause to mimic menopause. And like anything else, there was a lot of abuse in the use of testosterone, and you can see here from this Time magazine that they were complaining about the abuse of men who are getting testosterone, and it was all industry driven. And to their point, a lot of it is abuse, but a lot of it is warranted, and I'll discuss it a little bit. So like I said, it is a medical condition, not just a normal part of aging when it is associated with symptoms. There are two types of low testosterone. Either the brain is not sending enough signal to the testicles to produce testosterone, or the brain is sending an appropriate message to the testicles, but the testicles are not responding enough to produce testosterone. And according to the reason, we have different treatment options. We base the diagnosis on symptoms, on physical exam, and on a simple blood test. All it takes is a blood test. We recommend doing the blood test in the morning between 8 and 11 a.m. because testosterone in the body goes the highest in the morning and then starts coming down during the day and into the evening. So, like I said, hypogonadism or low testosterone with symptoms increases with age, and as you can see here, 40s, 50s, 50, 60, up to the age of 80, about the proportion of patients who will have low testosterone, about 30%. So these numbers increase as you get older. Signs and symptoms of low testosterone: decreased libido or sexual desire, erectile dysfunction, decreased beard and body hair, decreased muscle mass, loss of bone mass and osteoporosis, mental and emotional changes, fatigue, disinterest, inability to work out, difficulty concentrating, and sometimes some men will get hot flashes. We talked a little bit earlier about the metabolic syndrome. The metabolic syndrome is a constellation of obesity, hypertension, dyslipidemia, high glucose or diabetes, and insulin resistance. And this is on the rise, especially in the industrialized world, because of what we eat and the lifestyle. But low testosterone is associated with all these conditions, and all these conditions are associated with low testosterone. So that direction goes both ways. So often when we correct testosterone in men, we're able to help reverse or at least control these conditions better. And when you can do this, you can avoid the metabolic syndrome, and then you can avoid more inflammation and heart problems. So when we do testosterone tests in older men, in younger men, we just do a straight up testosterone level. In older men, the testosterone is going down, but the free testosterone also goes down even further. The free testosterone is the amount of testosterone in the body that the man can use. There are enzymes that attach to testosterone and make it not usable. As a man gets older, these enzymes go up. So the total testosterone is coming down, the enzymes are going up, so their free testosterone that they can use goes down even more significantly. So whenever you get a testosterone, it's important to get a free testosterone as well. So what are the benefits of testosterone replacement? Improved libido, increased energy, improved erectile function, increased body muscle mass, reduced fat, maintain bone density, improve cognition and concentration, improved all elements of the metabolic syndrome. Likely, and I say likely because there is still some controversy about it, but reduce cardiovascular events. I'll show you, I'm not going to get too scientific, but I'll show you here. This is the coronary artery score. This is the odds of you getting a coronary artery event, either a heart attack or an MI or anything like that. And this is testosterone levels. And you can see as the testosterone levels go up, the risk of getting a cardiovascular event goes down because low testosterone is associated with inflammation. Inflammation is associated with plaque formation in the heart and heart attacks. This is a study from the VA. They looked at 1,000 men aged more than 40 with a low testosterone and symptoms. And what they did is they took one group and they treated them with testosterone, and the other group they didn't treat them. If you look at the shaded line, these are the treated men. This is survival. So the higher, the better the survival. And you can see that the men who were treated with testosterone had a better survival than the men who were not treated with testosterone. And the way I explain it to patients is everybody's afraid of testosterone because there is this perception that you don't need it, it's for bodybuilders. The way I look at it, if your testosterone is low and you have symptoms, it's the equivalent of having a thyroid hormone that is low when you have symptoms, or that you're diabetic and your insulin is low and you have symptoms. You're not going to just walk around with these low levels. You're going to correct it to normal levels. And it's the same thing with testosterone. We're not trying to make you a huge bodybuilder. We're just trying to bring you back to normal levels. Hip fractures in the aging males. Also, they looked at men with hip fractures and they looked at a control group of men who didn't have hip fractures. Men who had hip fractures had a significantly higher rate of low testosterone compared to men who didn't. This is bone mineral density. So this is what a predictor of osteoporosis and osteopenia. Same thing. Men with low testosterone who were treated with placebo, so basically no treatment, had a significantly lower bone mineral density compared to men who were treated with testosterone. So again, testosterone preserves and protects bone mineral density. Depression. Again, they took men and they looked at their testosterone. They looked at men with low testosterone and they treated them either with placebo, the red line, or with placebo, the green line, or testosterone, the red line. The men who were treated with placebo had significantly higher depression rates. And that's usually because these men have lower energy levels and have less energy to go, and often because their erectile function is not as good. Their sexual desire is not as good. Usually when you fix someone's sexual function, their depression goes down a little bit. So what are the options for testosterone replacement? So in younger men, I'm not showing it here, but in younger men, when you want to give them testosterone, if I give testosterone to a younger man, then that person will become infertile. You will not be able to have children. So in younger men, we don't give testosterone. It's like a contraceptive, basically. In older men who are not planning on having children, or even younger men who don't plan on having children, then we can give testosterone. And those who still want to have children, we have other medication that we can give that promote your own body to produce testosterone and don't affect your fertility. This is a busy slide, but I'll show you all the different ways we can do it. We have gels or topical applications. This is topical, this is topical, this is topical, this is topical. It just depends on how you apply it and where you apply it. This is a spray that you can apply inside the nose. It sounds like a great idea. It doesn't work very well. We also have injections. These are the injections that for testosterone. These are the most commonly used. We usually give men injections every week or every 2 weeks because testosterone lasts in the body for 2 weeks. This is a long-lasting injection that lasts in the body for 8 weeks. I'm not very fond of it just because it's very difficult to adjust the dose. So it's always important that whenever you get any kind of treatment, that the dose is adjustable, and you can't adjust the dose very much with it. So I don't use it that frequently. And then finally, these are the testosterone pellets. These are, I don't know if it shows, these are pellets that are implantable under the skin in the clinic with local anesthesia. It takes about 5 minutes, and they last in the body for 3 to 4 months. So the onus is not on you to give yourself the applications or the treatment. You just come to the urologist, get your shots or your pellets, and you come back 3 to 4 months later. They work pretty well. We don't have any oral testosterone replacement to date. Almost passed FDA approval in October, but they didn't. They might be trying again for next year, but we'll see. For now, we don't. The problem is with the oral is that you require a lot of fat consumption for the testosterone to be absorbed by the body, so that is obviously not a great thing. Now I'm going to touch on BPH, and it's going to be the last part of the presentation. So BPH is an enlargement of the prostate. So if you look on the left side, this is what the bladder. This is a little bit urine in the bladder. This is the prostate. This is the urethra. So you can imagine when you urinate, the urine is coming here through the prostate into the urethra to the outside. So you require that your prostate not be obstructing the urine passage for you to be able to pee freely. This is an enlarged prostate, and you can see here multiple things are happening. One, the prostate is enlarged, so that passageway here becomes more restricted. The second thing that you notice is the bladder wall here, you compare it here to here, has become thickened because the bladder is a muscle. So now the bladder is having to generate more pressure to pass that urine through a tighter passageway. And that's when men start having to strain to urinate. And what happens when the muscle gets thicker, basically the bladder fatigues. It's like any other muscle in the body, and it stops functioning really well. And over time, something can happen which is called an overactive bladder. So because of this, the bladder can't generate enough pressure to empty the bladder. So it kind of starts doing a little bit of this, and the men start going to the bathroom every hour or every 2 hours, and they go and they're like, I don't have that much to urinate anyway. It's just because the bladder is not able to generate enough pressure anymore. And the third thing that happens is urine does not empty from the bladder. This can carry a lot of issues. One problem that happens from this is you can get urine infections. When the urine stagnates in the bladder, it can cause infections. The other thing is, it's not shown on the image here, but the bladder is attached to the kidneys through 2 tubes called the ureters. When the kidney is not able to drain into the bladder, you can have kidney problems. Here's another better visualization of what it looks like. So this is a normal prostate. So this is the bladder, this is the prostate, and this is the urethra. And you can see the passageway in this case is open, so the urine comes out freely. Now the prostate is starting to enlarge. The reason it looks like this is the prostate is a gland, so this is glandular tissue. As the prostate starts enlarging, you can see here you're not seeing that black part in the back, which is the bladder. The reason it's black is the shadow of the bladder. So now you can't see it anymore, and it's getting a little bit more obstructed. As the prostate gets even bigger and more obstructive, you can see here the 2 sides of the prostate completely start obstructing the urine, and some men can go into urinary retention, which means they can't urinate at all, and that becomes obviously an emergency. BPH, also a disease of the older men. It occurs in 26% of men in their 40s, 50% of men in their 50s and 60s, and up to 90% of men in their 70s and 80s. But we don't jump and operate or give medication to everybody. As long as a man is able to empty his bladder, he's not getting any complications from the enlarged prostate, or his bother is low from all of these. So when all of these things are checked, then we don't need to do anything more than give advice about things to prevent further enlargement or to improve urination. Otherwise, we have to do interventions. But before we do interventions, we're going to try to figure out how bad the problem is. So we have a questionnaire. This is called the IPSS questionnaire. It's a validated questionnaire for enlarged prostate. So the questions that we ask is, do you feel like you're completely emptying your bladder? Which means once you finish urinating, do you go back, have to come back to urinate a second time? Often that's the only complaint that some men have, and I just tell them, once you finish urinating, don't leave the bathroom. Just stand there for an extra minute. Everybody has their phone everywhere with them now. Just hold your phone, send an email. Don't take a picture, send an email, wait a minute, and urinate again once you've relaxed. And that helps out sometimes. And that sometimes is just solves the whole problem. Frequency. Urinating frequently, and we talked about that's because the bladder is not emptying. Intermittency, that's basically when a man starts urinating, but the stream is not continuous. The stream comes and goes and comes and goes, and that can be quite troublesome. Urgency is when a man needs to rush to the bathroom to pee frequently. Weak stream is self-explanatory. Straining is when a man has to push to urinate. And what I showed you earlier, because of the obstruction, you have to generate more pressure in your abdomen to be able to push that urine. So the bladder is not able to generate that pressure anymore. So men will have to squeeze to do it. Nocturia, which you see here as number 7, means waking up at night to urinate. And it's important for us as urologists to recognize whether that nocturia is because of the PPH or because the kidneys are overproducing urine, which would be treated differently. If it is because of enlarged prostate, but also if it's because of the kidney, we usually tell men not to drink any water in the afternoon or early evening, because then you're going to have to go urinate. The other things that we tell men is to avoid things that are irritants to the bladder, such as cigarettes, but more commonly coffee, tea that is caffeinated, and all the soft drinks that are caffeinated. All of these are irritants to the bladder and are going to make you want to go pee frequently. I often get men who are referred for an enlarged prostate, and when I talk to them, they tell me they have 6 cups of coffee and four iced teas during a day. I tell them if I did this, I'd go to the bathroom every 20 minutes. That's just the bladder is going to be responsive. Complications of BPH: urinary retention means you can't pee at all anymore. Renal failure, because these are the tubes that connect the kidneys to the bladder. Once the bladder can't empty, these can't empty what's coming down from the kidneys. Recurrent urine infections, you can get stones in the bladder, and blood in the urine is another one. So how do we work up men with an enlarged prostate? We take a history, we do a physical exam with a rectal exam to check the size of the prostate. We do a test of the urine. We check the PSA, the blood test for screening of prostate cancer, because often the PSA will go up with an enlarged prostate. The PSA is secreted by all the prostates. As the prostate is small, it only secretes a certain amount of PSA. If the prostate gets bigger, the amount that is secreted by the prostate of PSA is going to be higher in the bloodstream. Now, the reason men who have cancer get higher PSA numbers is the cancer cells shed. So when they shed, they go into the bloodstream. So that PSA number is going to go up. And that's how we use the PSA to screen for prostate cancer. But the PSA in itself, sometimes not that helpful. We have some adjunct tests that we can do also to make sure there is no cancer. But we also have MRIs now that we're able to do just tell us if there are anything that is suspicious for cancer. But I will tell you that the question is often asked by patients, having difficulty urinating, is it cancer? For a cancer to cause difficulty urinating, it has to be a very, very advanced prostate cancer, which we almost never see. So most of the time, when you have an enlarged prostate, when you have difficulty urinating, it's because of a benign enlarged prostate. It's not because of cancer. Cancer is only detectable, or most commonly detectable, by screening with either a finger exam or a blood test or an MRI, not through physical symptoms or clinical symptoms. We use a questionnaire that I showed you just a second ago. This is a very special toilet we have in the clinic. It requires good aim. You're going to aim here. It's going to tell us how strong you're urinating, and it's going to tell us afterwards how much is left in your bladder. After you urinate, we scan your bladder. And this gives us an idea about how if there is any obstruction at any point. And the last thing is a cystoscopy, which is the equivalent of colonoscopy, but from urethra. We go in through the penis into the bladder, and we look at the bladder, and we look at the prostate. And I apologize, I used the picture of a female here because there's a vagina, so obviously that's not a male cystoscopy. Those of you who noted are good at anatomy. So treatment options: watchful waiting, medical management, minimally invasive therapies, and this is a new thing that we now can offer, and I'll discuss it, in surgery. In terms of medication, there's a ton of them. You probably have heard of the words Flomax, Cardura, Rapaflo. These are the most commonly used medications. Urological. They're all more or less similar. Some of them need to have the doses adjusted, some don't, but all of them may cause a little bit of drop in the blood pressure, especially in men who take blood pressure medications. They all can cause retrograde ejaculation. Retrograde ejaculation is sometimes quite problematic, which means you have sex, you orgasm, but there's no ejaculate that comes to the outside. And the reason this happens, if we go back to this image here, when the ejaculatory ducts where the ejaculate comes out when a man ejaculates are located in the prostate. When a man takes a medication for their prostate, the connection between the bladder and the prostate relaxes. So what happens, the ejaculate preferentially goes into the bladder instead of coming outside. You'll end up urinating afterwards whatever you were supposed to ejaculate. But in some men who are sexually active, that's quite problematic. One of the medications that is listed here, alfuzosin, causes much less retrograde ejaculation than the others. Although it is an older medication, that's my preferred one to use for BPH. And this is very important. There is data to support that these medications, particularly tamsulosin, which is Flomax, the most common one, is dangerous in men who are about to get cataract surgery. So you have to speak to your ophthalmologist before you get cataract surgery to get off these medications, because cataract's also a condition more common in older men, and so is BPH. So often men will have both conditions at once. These are another family of medications. These you might know of them more as Proscar and Avidart. Finasteride is Proscar, but it's also I'm blocking on the name, for hair loss, the medication they use for hair loss. It is finasteride, but there's another name for the anyway, both of these medications, they work by shrinking the size of the prostate. You can use them in combination with the first line of medications that I showed you. I don't like to use them very often because they cause significant sexual dysfunction. So all of these medications are anti-hormonal, so they block the conversion of testosterone to another kind of testosterone. So they will worsen erectile function, they will worsen ejaculation, and there is data to support that even after you stop these medications, the sexual dysfunction will continue lifelong. So I don't tend to prescribe them a lot, except in really older men who are not sexually active at all, have significant problems, do not want to undergo surgery, then we'll use these medications. But now we have better alternatives. There's also recent data to support that they may cause cognitive impairment, so obviously you want to avoid those. So this is TURP, or transurethral resection of the prostate. This is the Root-A-Router. This is the most common procedure done for enlarged prostate. It can be done either with electricity, like you can see it here, or it can be done with laser. The concept's pretty simple. We've memorized this by now. This is the bladder, this is the prostate, this is the urethra. We're gonna go in and we're just gonna scrape that tissue out on both sides, and we're gonna make a nice big passageway for you to be able to urinate better. It's a surgery that is outpatient, or you can stay in the hospital overnight and leave in the morning. It has a very high success rate, but it does carry some complications. You can have some bleeding afterwards. Very rarely, in less than 1% of men, you can have some incontinence or leakage of urine afterwards. There's controversial data that suggests that you can have worsening erectile function afterwards. I don't really believe it that much, but there is some data to suggest it. But one thing that will happen in almost all patients, not all, but in the majority, is after the surgery, you will no longer ejaculate to the outside. Every time you have sex and your orgasm, your ejaculate will go backwards into the bladder. And that tends to be a big problem for a lot of men. So that's one thing to keep in mind. So in the past, the only options we had were either medication, and if the medication didn't work, we'll go straight to surgery, which requires general anesthesia, or at least an anesthesia of half your body, or spinal anesthesia. We now have options that we can do in the clinic. So this is the UroLift. These are prostate sutures that we put inside. The advantage of these are done under local anesthesia in the clinic. We just put some gel through the tip of the penis. We'll give the patient a Xanax and a pain medication an hour before the procedure. If you can't get off your anticoagulation medication, if a man is on aspirin or Coumadin or Eliquis, we will occasionally do it on those medications as well. The nice thing about this is you come into the clinic, you get the procedure done. It takes about 5 minutes. You get up and you walk home without a catheter. The success rate with these procedures is actually pretty high. The data shows that there's about a 60% improvement in your urine symptoms before and after the procedure, and the data now is as long as 5 years. So it shows that even over 5 years, the chances that you will need anything else done is about 1 to 2% every year. So it's really low. The risks of bleeding are almost zero. They're very low. The risk of incontinence is zero, but also importantly, it does not cause any problems with ejaculations afterwards. What we do is we go in with a little camera. This is our camera. We put little sutures on either side, and as you can see here, whereas these two lobes of the prostate were stuck to each other, we're just basically going to mechanically push them apart from each other. This is the prostate, if you remember the images I showed you earlier of an obstructed prostate, and this is after UroLift, and you can see the bladder on the back. So it works pretty well. This is a newer technology that is starting to make its way into the market. Now it's 2 years in. We just started adopting it at UCI, and we'll start using it soon. Same thing, local anesthesia, just Xanax and a pain medication before the procedure. You don't need to be put to sleep. You go home immediately afterwards. You will require a catheter for a few days after this procedure, and this uses basically water vapor. So again, same thing. This is the tip end of the scope, the camera that we're going to put in, and that little plastic needle is going to go into the prostate, and this is the prostate before it gets treated, and this is afterwards. It's just basically vaporizes the tissues inside and it makes a passageway. It works very nicely. The data at the 2-year mark is very positive, so that's a great option for the future. I don't have a slide here, but at UCI, we're one of the clinical trial centers for a new procedure that uses a robot that goes to the tip of the urethra. It sounds scary. It's not the whole robot goes to the tip of the urethra. There's a little scope that goes to the tip of the urethra, and it's attached to a robot, just to clarify. And it uses the ultrasound done at the same time, and it just vaporizes the prostate from the inside. It takes about 4 minutes to do the procedure, and it's been shown in a large clinical trial to be better than the Roto-Rooter. We're now doing the clinical trial at the VA in Long Beach, and we should have it at UCI hopefully within the next year. And in conclusion, the population is aging. Men are living longer and continuing to be active and working later in life. Aging is among the greatest known risk factors for most human diseases, including urological conditions. As men age, they develop more comorbidities, and urinary, sexual, and hormonal issues are common urological conditions that are more prevalent with aging and should be adequately screened for and managed. And we really have truly great options for most of these, for all of these conditions. But it's important to know about them. It's also important to know that we have options for treatment. And again, I'll reemphasize the point about, because I sit on the board of the Sexual Medicine Society of North America and International one, and I have a passion for quality of life. And I'll say what I said earlier. Often patients are reluctant about trying to fix their sexual dysfunction because they just use the argument that they're older, although they do feel that they want to be sexually active. There really is no age cutoff. We have, obviously, if a patient's not interested anymore and their partner is not interested, then that's it. And sometimes the patients are interested, but their partners have medical issues. And again, this is a one-sided conversation right now because I'm not discussing female sexual dysfunction, which is a topic that is as large as this one. But in terms of when both partners are willing, we have ways of doing it. We've put implants in men who are as old as 89, and they're very happy. I'm not saying that all men at age 89 should get an implant, but I'm saying that if you are interested, there really is no age cutoff. Thank you.
A lot of good, you were talking about testosterone treatments. Is there any negative to, side effects of testosterone, specifically to how it affects prostate, or could add fuel to patients who might have prostate cancer and don't know?
That's an excellent question. I was asked to repeat the question every time they're asked for the recording. So the question is, we talked about all the positives about testosterone. Are there any negatives? And specifically pertaining to prostate and to men who are at risk for prostate cancer, correct? So there are risks with prostate with testosterone replacement. All the risks are diminished significantly when you're doing it in a scientific and in a correct way. And I'll go back to a lot of the bad reputation that came to testosterone is because of 20% of physicians prescribe testosterone without checking levels. And a lot of patients get testosterone and use them for bodybuilding purposes. We've all seen on the magazines an 80-year-old man who's flexing, showing that he's on testosterone, life is great. So obviously that's not the goal of it. When you do it this way, the risks are high. When you do it appropriately, the risks are really low. And the risks of testosterone, and what I'll give you the spiel that I give every patient. Any man who goes on testosterone, there is a chance his PSA might go up a little bit. The number of articles that have clearly showed that testosterone causes prostate cancer is 0. So there is no data. So the old data that has been perpetuated that testosterone causes prostate cancer comes from a study from 1941 that had one patient
who received very high doses of testosterone and ended up with prostate cancer. So we actually now give testosterone to a fair amount of patients who are known with prostate cancer, either treated or untreated. That being said, there is something called the saturation model. I'm not going to go into too much details, but the prostate can only take this much testosterone, okay? Anything you give the prostate beyond this amount of testosterone, it makes no difference on the prostate anymore. It's saturated with testosterone. Now, when the cutoff for low testosterone that we use for treatment is over here, right? So the men I'm treating are coming with a testosterone here, and I'm correcting that testosterone to bring it to here. So that prostate is already saturated. So that makes no difference, that testosterone that I'm giving on the prostate. What it does make a difference is men who have a metastasis from their prostate cancer, spread from their prostate cancer. Testosterone is fuel for the prostate. So for those men, we basically bring their testosterone down to zero. We give them medication to bring that testosterone to zero. Any testosterone from there that we give them might feed the cancer. But in men, otherwise, after this amount of testosterone, it's saturated. So there's actually even some data to support that low testosterone is associated with higher risk prostate cancer. So again, it's like anything else in life. It's risk-benefit, and it's about doing it in a proper way. For example, when I put men on testosterone is a controlled substance. You need a printed prescription. If the men don't do their blood work on time, they don't get a renewal of their prescription. So if you do it this way, I've not had a single man develop prostate cancer due to testosterone. I've not had a single person have a heart attack or a stroke because of testosterone. The other parts of the risk of testosterone is that testosterone increases the density of the blood, or increases the amount of blood that you have. It's called erythrocytosis. In the past, in the old days, we used to give men testosterone men who had anemia. We used to give them testosterone to bring up their numbers. There is concern that if these numbers go up too high, that you're a higher risk for heart attacks and stroke because your blood gets denser and thicker. That these data also come from very old literature from the endocrinologist, and they use the cutoff number that is 54 for the erythrocytosis that has never been replicated and has never been proven. That being said, we use it as well, just mostly I guess for medical legal purposes. But if you lived in Denver, or you lived in the mountains somewhere, if you lived in anywhere of an altitude, your hematocrit is going to be significantly higher. That's because the oxygen is less, so you have to produce more hematocrit to catch all that oxygen. So that being said, and these men don't get more heart attacks or strokes. The third thing is, and I know I'm making this a long answer, but this is a very important question that you asked, is does testosterone all out cause heart attacks and strokes? And I'm sure you've seen all the advertisements. The lawyers have put out a lot of advertisements. If you've taken testosterone, you have a heart attack or a stroke, come and see us. And I'm not saying that it doesn't. I'm saying it does if you're doing it and you're getting really high testosterone shots with numbers that are out of this world. So I get patients to come to see me who are numbers that are ridiculous. Their numbers are so high that they don't even show up on the panel that we have. These men are at a high risk of heart attacks and strokes. But men who are getting from low numbers of testosterone to normal levels of testosterone are not at higher levels. The two studies that got the FDA, the New York Times, and everybody all excited and triggered all these lawsuits and all these lawyers going after this were based on two studies, one of which is the major study of both that has been changed. The results of the study have been changed in the literature at least 3 or 4 times because of complaints that it was poorly done. And when the data was reanalyzed, it actually showed that men who got testosterone had half the chance of dying than those who didn't. And there's much more data to support that testosterone is protective to the heart. So I would argue that it is protective to the heart, but only if it's done in the right way. Yeah, you're welcome.
My question is about tamsulosin and the effect on cataract surgery. And since as people age, the increase of incidence of needing cataract surgery increases, 2 questions. Number 1, would you recommend that a different drug be used? And number 2, if you go off it, is the risk of cataract surgery, is that risk reduced?
So it's a good question. Not all the ophthalmologists agree that it does cause it. So it is a slightly controversial topic. Some ophthalmologists will keep the patients on it, and there's a lot of debate as to how long you need to be off of it for it to be safe. What we usually do is we discuss it with the patient, and we'll tell the patients to go see their ophthalmologist, ask them if they need to get off of it before. We always inform the patients that we start on it, we start the medication, that this might happen. Now with the newer options that we have, procedures that we can do in the clinic, we can work around the side effects of these medications. Because the problem is, as we're moving further and further in time, we're realizing that a lot of the medications that we use have a lot of side effects that we didn't know of or we didn't care that much about. So for example, like I said, the other medications for BPH now are being shown to cause cognitive impairment and prolonged sexual dysfunction. With the alpha blockers, often which is like Flomax, that cause drop in blood pressure, that cause retrograde ejaculation. When it comes to the cataract, I usually tell my patients to go, because all the alpha blockers can cause it, not just the Flomax. The Flomax is the most common one, but I tell them to speak to their ophthalmologist, and I leave it at the discretion of the ophthalmologist. I've had ophthalmologists tell me before, well, he doesn't need to stop it, just keep him on it. So I'll just let them decide that. Sorry.
I've heard of people going to Europe for BPH treatment, specifically Germany. Was that what you were talking about?
So one of those. So in Europe, they're usually early adopters of technology, and the reason is, well, I wouldn't say early adopters of technology. They're where the trials are done, and the reason is the FDA. Well, the equivalent of the FDA is not as stringent over there, so it's easier. At the University of California, we're even more stringent in the fact that we wait for mature data before we adopt something, unless we're part of a clinical trial. So I've been at UCI for a year. I adopted UroLift from day one because I thought the data was mature enough and we're seeing great results. Resume waited for the 2-year data and we've just adopted it. The aquablation, which is the new thing, which is the only place where it's been done outside of the clinical trial so far is Germany. We are doing the clinical trial for very large prostates at the VA, and we're probably going to have it next year. So again, your question was about other technologies and the reasons why people go to Europe to get treatment for BPH. It's just because they have much less stringent restrictions over there. Yeah.
Thank you.
Yeah.
What about the procedure called pull-back? I understand that that's more effective than the TURP with fewer side effects, but that the training is extensive, so doctors and doctors.
So the question. Yeah, so the question is about a hold-up for enlarged prostate and the fact that it is more efficient than a TURP with less side effect profile, and that it's not being adopted because doctors have less of an experience with it. And my answer is yes to everything said. So hold-up is great. Hold-up is holmium laser enucleation of the prostate. So we basically enucleate the prostate completely and we take it out. It works really nicely. I used to do it a lot in my training, in my residency, and I did my training in Canada at McGill. The gentleman who did the most in the world was there, so I've done quite a bit during my residency. It has a very high learning curve. It's very difficult to do. And the problem with it is, it's only validated to be done with really large prostates. So there is no reason to do it if someone's prostate is small. So it's only for very large prostates. So it would be anywhere over 100, 120 gram prostates. And hold-up works really well. And I'll tell you, if it's not done in the right hands, it can be a disaster. I unfortunately do not have a preference for doing hold-up. So at UCI, what we do is for incredibly large prostates, we routinely do a robotic simple prostatectomy, which is we do like a robotic prostatectomy for cancer, but we take much less of the surrounding tissues and we just take out the prostate, and it works very well. That being said, with the new aquablation that I'm talking about, that we're doing the clinical trial at the VA, that's I think is going to be the future for very large prostates, because we're able to treat a prostate that is 300 grams, which the normal prostate is 30 grams. We can treat a 300 gram prostate in 4 minutes, and I think that's going to be the future for very large prostates.
So if you were able to look at a physician that was very experienced with pull-up, are you comfortable that that has fewer side effects than TURP?
I wouldn't say it has fewer side effects than TURP. It carries the same side effects as TURP. It just carries less side effects than TURP for a very, very large prostate. If it was a smaller prostate, the side effect profile will probably be worse with hold-up, because with hold-up you have to do something called morcellation, which is after the prostate is enucleated, there's this big lump that is inside the bladder, and you have to go and break it down in the bladder, and that carries complication. But if it's a very, very large prostate, we can't do it with an abnormal TURP because that would require 5 hours of surgery to do it with complications. But someone with a very, very large prostate, if there is a person around who's really good with the whole, then by all means, yes. Yes, sir.
This is slightly off the topic, but this is about incontinence due to after prostate surgery. In the last, say, 5-10 years, are there new methods to treat the incontinence?
So the question is about incontinence after prostate surgery. So there are two sphincters in a man. After prostate surgery, we remove one of those sphincters, so then you're only dependent on your ability to control urine. So there is about a 10% chance of incontinence after prostate surgery. It's very important to know what the reason for the incontinence is. Incontinence can be either because the bladder is contracting too much, or because the sphincter is not working, or a combination of both. And depending on the reason, we do the treatment. If it's the bladder that's the problem, we do medications and lifestyle changes. If it's the sphincter, we recommend the exercises, the Kegel exercises, which obviously are not going to work for everybody. Beyond that, we have slings. These are a mesh that is applied under the urethra, and it uses your own pressure that you generate when you're about to urinate it causes a hammock effect. Basically, it pushes the urethra up and obstructs it so you don't leak. It works well for men with very little incontinence. Now, if you have more incontinence, then the best option is something that I do as well. It's called an artificial urinary sphincter, which is basically a cuff that is placed around the urethra. If you remember the inflatable implant that I showed, it's very similar to it, and it was invented 40 years ago by the same guy who invented the implant. It's a cuff around the urethra, a little pump between the testicles, and a reservoir in the belly. The cuff is always closed. When you press the pump, the cuff opens up because the water that is in the cuff will go to the reservoir and it clears up and you can urinate. There are newer iterations to these things that are in the works. We're working on one of them right now, but we don't, right now, commercially available in the United States, this is what's available in terms of surgical management of incontinence after prostatectomy in males. I think there's a couple of questions here. I'm just going to read them here. Well, this one must have been written by a doctor. I am 86 years old with prostate cancer and radiation treatments. PSA is 1.3. I am totally dysfunctional sexually. Is it possible that my I think its function can be returned as much as possible to its original form. So, in terms of sexual dysfunction, so yes, so in general, if you had prostatectomy and radiation, so prostate surgery for erectile dysfunction, what it does is, if this is where you started, and this is 2-3 years afterwards. After prostate surgery, your erectile function gets worse immediately afterwards, and then over 2 years or so, it kind of starts recovering slowly to this new baseline. Sometimes it goes back to where it was before, but usually it's a little bit less. With radiation therapy, once you get radiated, your erection will not change initially, and then over time, it will start decreasing at around 2 to 3. So basically, you get a little bit of both. When you get both of them, you're going to get even worsening erections. If you have hormonal therapy as well for advanced cancer, your erections are going to be even worse afterwards. In these men, returning sexual function would depend on what kind of treatment is needed. So like I said, we have a big armamentarium of treatments. We would need to check what the reason for the erectile function is by doing the ultrasound that I showed earlier with the fancy images. We tried the pills, which there's a good chance it might not work. We tried the injections, which have a very good chance of working. There's the vacuum device, but there's also surgery. So often in these situations, surgery is the next option. And sometimes when men do have erectile dysfunction after surgery and radiation, they'll have some amount of leakage. We also have a little procedure that we can do at the same time as the penile implant that controls incontinence. So yes, it can be corrected and it can be restored, the sexual function, but it's important to note that what we do to this day in terms of sexual function is we're able to return sexual function, but we're not curing the problem. We're fixing the problem, but we're not bringing your erections back to where they were before. We were starting to look more and more at stem cell therapy for erectile function. I would not recommend at all for anybody to proceed with stem cells for erectile dysfunction at this point. The data is very soft and it's actually still dangerous. There are men who got stem cells for their eyes in Florida and lost their vision. So stem cells are the future, I think, but we're not there yet. The second question is, what do you think of the TURP procedure to improve overall function and how long does it last? I'm on blood thinners. So again, TURP works really nicely. If you're on blood thinners, you have to stop your blood thinners before a TURP. There are other options. We do laser treatments for the prostate that we can do without having you stop your blood thinners, so that would be another option. But TURP is still considered the gold standard for large prostates. So for large prostates up to a certain amount, not very, very large prostates like you were talking about earlier, TURP is still considered the standard of care with the best outcomes. Now, the treatment that I was talking about earlier, head-to-head with TURP showed better outcomes, and it didn't matter if the patients were on blood thinners, but it's still not commercially available. So for now, TURP is still considered the standard of care. Third one is, how do you measure testosterone blood tests? It's just a simple blood draw. You can do it anywhere. It has special test tubes, but you don't have to worry about it. Just your primary care physician, your urologist, just ask for a testosterone level. It has to be done in the morning between 8 and 11. Otherwise, your numbers are going to look lower than they are. And the reason it makes a difference is the standardized results that we look at compare values that are done between 8 and 11. And why does the prostate enlarge? What causes enlargement? That's a very difficult question to answer, but the prostate enlarges for many reasons. One is genetics. So a lot of men with an enlarged prostate have a family history of enlarged prostate. It also has to do with some dietary factors. There's some data that suggests a high consumption of red meat causes a large prostate. I have a dietitian at home, so I can tell you that she doesn't recommend not to have red meat, just to have the good kind of red meat, not the processed, non-organic, non-grass-fed red meat. So processed food in general will cause inflammation. Inflammation will cause an enlarged prostate. So that's another thing. And the third thing is we have, again, I didn't show it here, but there's data to show the same thing that I showed, that low testosterone is associated with the metabolic syndrome. Enlarged prostate is associated with the metabolic syndrome. They share a common pathway of inflammation, and with the environmental factors, what we eat, what we put in our bodies, these things can lead to a large prostate. And the last question is, I guess that's the question about the whole loop. Yeah, so that's the same question. I think that was the last question. There's one more. When you were discussing finasteride, were you thinking the other one was Proscar? I take finasteride in small amounts 6 times per week to reduce balding. I have felt no symptoms over 3 to 4 years. I'm 61, but worry about what you said about increasing risk of dementia, etc. From finasteride, though I take a small amount. So I'm blocking on the name. So finasteride 5 milligrams is Proscar. Finasteride 1 milligram is another commercial name, and I'm blocking on the name right now, unfortunately. But Rogaine, yeah. So the 5 milligrams of the data for the sexual dysfunction long term is for both the 5 milligram and the 1 milligram of finasteride, so both of them. Now the data for the dementia or cognitive impairment long term is not very strong data. It's not level 1 evidence, but it is there, but it's was for the 5 milligrams of finasteride. I usually recommend against these medications because they are anti-hormonal, and because I am in sexual dysfunction, I don't like to block hormones. That being said, if you are not getting any symptoms, you're not sexually active, or you are sexually active, then your erections are fine, and you don't feel like it's causing significant side effects, I can't tell you to stop it, but I usually recommend against it.
One more?
Everybody wants to know about ancestral diseases and issues. And if you were compiling a file for a new doctor,
what kinds of things would you ask about with respect to sexual function?
So the question is, in terms of we're all looking into ancestral diseases and through the ancestry registries, and you're asking in terms of sexual dysfunction, what are the questions that I would ask a doctor about that might affect that? Is that it?
Or diseases that might have a bearing on your field, for example.
So I like to think that I do, although I am labeled as a mental health specialist entitled, which makes it sound like it's sexual dysfunction, but we do comprehensive mental health, and I'm not showing it here, but we're opening soon a clinic in Newport Beach where we're going to be doing comprehensive mental health, which is you come in and we do everything. We check you for diet, we're going to be seen by a dietitian, we also check you for all kinds of testing for inflammatory genetic markers, and we screen you for diabetes, hypertension. Also, for my clinic right now, I do clinics in both Orange and Tustin. For all my patients, I screen them for all the conditions that are available that can be affecting erectile function. If I get a younger man with erectile dysfunction or low testosterone, I will screen them for diabetes, hypertension, thyroid levels. I check the sex hormone binding globulin, which is what binds testosterone, and sometimes that number is high, and I check thyroid function tests and liver function tests because that can be contributory. So the advantage of sexual dysfunction and voiding dysfunction is that it's a gateway for patients to come into a clinic. Men will not go to a doctor, but once the plumbing stops working, they'll start coming. And so we use that for screening. That being said, the questions I would ask would be, I ask about all family history of any cancers. Prostate cancer is the one with the highest familial factor in terms of urology. We recommend, the American Urology Association recommends screening between the ages of 55 to 69. Previously it was 50 to 74 to 75. We screen earlier in men who have family history. There is debate as to whether we should screen everybody once at the age of 40 and not screen again for another 10 years and wait, because that gives you an idea into the future. There's a lot of debate. The problem with screening often with everything is it triggers treatment. And whenever anything triggers treatment, it sometimes triggers treatment that is not needed. For example, in the past, we used to remove everybody's prostate whenever they had cancer, and everybody ended up with problems afterwards, and that's how my specialty came into place. I'm maybe thankful older for that, but I'm just kidding. But because of that, it's important to always discuss the risk or benefit of any screening test, because screening tests can have as much complications as not screening sometimes. Because finding out something that is not necessarily, going to kill you or alter your life. For example, if I get a man in his 80s who's had normal PSAs in the past and comes and wants to be screened for PSA, I discuss with him at length that why do you want to be screened? If we find something, it's going to make you want to get something done, and you're probably more than, I can't tell you percentage, likely to die from any other reason, being hit by lightning than dying from your prostate cancer. So that's the risk benefit of anything we do. Yeah.
One more question. Roger, go ahead.
And non-medical, but just if you feel like mentioning this impressive presentation coming from Beirut, rough part of the world, and how did you get involved in your interest in medicine, and what was it like coming from Beirut? Maybe you spend most of your time in Canada. It's an interesting journey that you've been on and got into medicine.
Thank you. For those who didn't hear the question, he was just saying how wonderful I am. I'm just kidding. Just kidding. So I lived a little bit all over the world, like a good Lebanese immigrant because of civil wars. So I was born in Lebanon, grew up in France, Lebanon, Saudi Arabia, and Canada. A naturalized Canadian when we were younger, and then went back to Lebanon, did my undergrad and my medical school there, and I was on track to becoming a urologist there. So I did a year of surgery, and then there was war, so I left and I went to the Mayo Clinic in Minnesota where I was doing general surgery, then switched to Canada, being Canadian, did 2 years of research in bladder cancer, and then I was doing my residency, and they used to call me the bladder cancer guru because I love bladder cancer. Then I realized that we're treating cancer, but we're not treating the consequences of cancer. And I realized that men, they're happy, their cancer's gone, but then afterwards, all right, you can't do anything much, but you're gonna live another 20 years. So I realized that you can provide, excuse the term, that you can provide happy endings. So I decided to go into men's health, and I did my fellowship at Tulane with the president of the International Society for Sexual Medicine. UCR are pretty good at recruiting, and so I came here, and I'm very happy to be here. And, yeah.
Well, we are happy to have you. Thank you very much, Dr. Yafi.